today's speaker, someone who frankly needs very little introduction in our world, but deserves a great one anyway. Dr. Georges Benjamin is the executive director of the American Public Health Association, APHA, our nation's oldest and largest organization of public health professionals, founded in 1872. He has led APHA for over 23 years, which for those of us keeping score means he's now outlasted multiple pandemics, several administrations, and countless rounds of public health budget negotiations. And that alone, I think, deserves a round of applause. But Dr. Benjamin's journey to this role is really a remarkable one in its own right. He's a native of Chicago. He trained in internal medicine at Brooke Army Medical Center and fell in love with emergency medicine at a time when the specialty was really emerging as one. He went on to serve as chief of emergency medicine at Walter Reed, ran one of the busiest ambulance services in the nation in Washington, D.C., and served as the secretary of Maryland's Department of Health and Mental Hygiene, where he oversaw the expansion and improvement of the state's Medicaid program. That's also when I first became acquainted with him, because in the wake of 9/11, when we were both state health officers, we all had to stay in close touch during what then seemed like turbulent times. He is a member of the National Academy of Medicine, a master of the American College of Physicians, the author of more than 200 scientific articles and book chapters, and has been named one of the 100 most influential people in healthcare by Modern Healthcare for over a dozen years running. Washington Magazine has repeatedly named him one of the 500 most influential people shaping health policy. He's also the author of Public Health Under Siege, a book he wrote in 2021, which he's going to be talking about today, I believe. And given the current moment, it seems like someone said to me the other day, it feels like the book title is more like a daily briefing of the Public Health Under Siege. And given that it was published in 2021, I'm not so sure if Georges maybe had a special crystal ball or not. But what I admire most about Dr. Benjamin is that he brings the urgency of the emergency department to the long game of public health. He has been a steady, courageous, and unflinching voice for science, for equity, and for the foundational infrastructure that keeps communities healthy. At a time when that voice is needed more than ever, we are incredibly fortunate to have him with us today. So please join me in welcoming Dr. Georges Benjamin. Thank you. And he's going to talk, I think, and have some slides for a bit, and then he'll take some questions, I believe, and we'll have some conversation.
Yeah, the slides are coming. They bounce back.
It did. Okay, it may be too big a slide. I'm just going to show a few slides that are required for continuing education. And if so, I just want to make sure if people want continuing education, these are required slides that we present. If your PowerPoint bounced back, it may be too big for the file.
I sent it as a link. So did you get the link?
I have not got the link. If you see the share button as a presenter, but I will continue to
do this, and then
I'll monitor that.
We can walk through the share part.
Yeah. I just wanted to share these slides with folks and can put these in the chat for CMEs. And this is the phone number here and the code here, and you'll get it. You can do that by text. So I'm going to stop sharing and let me look and see. Yes, here the slides just arrived. So here we go. Open those, and then I can share these with everyone as well.
Let me just say that I don't have any financial disclosure or conflict of interest with today's presentation. And just to say, APHA's mission is, as a national leader, we want to ensure that public health values, fairness, dignity, access, and safety remain visible and protected. We serve as a convener, catalyst, and advocate to build capacity of the public health community. And for over 150 years, we've talked about champion optimal, equitable health and well-being for all, and trying to speak truth to power about public health issues and policies backed in science. And that's kind of been our perspective on this. A couple years ago, I and Brian Carstucci and a couple others published a book called Public Health Under Siege, which came out of a public policy institute that we had at APHA, and it was to discuss the power of policy at the federal, state, and local level. We looked at what happens with some of the policy overrides, like preemption, and we did a whole series of case studies to try to address the real world that we were living in right today. Go to the next slide.
And
Let me talk about the fact that we're having a lot of conversation today about democracy, and just remind everyone that the United States is a representative democracy. That's where the citizens elect our elected officials to represent our interest in government. But we're also a constitutional republic, and that means that the power is derived from the people, but exercised through those elected representatives under the fundamental rules of our U.S. Constitution and all the laws and regulations that are derivative of that. Understanding that Constitution limits government power and strives to protect individual rights, which is the foundation of our democracy. And fundamental to this system are principles like equity, the rule of law, and citizen participation through voting and other civic engagement. Next slide. So a democracy requires a broad civic culture where people have a voice and can participate in various ways. The ultimate power is from the people. The people are the ultimate power in our system. In our country, our power is divided between the national government, state governments, and delegated by the people to these governments. Voting, we again elect our officials to represent our interests, not their interests. And we have a responsibility for legal engagement. We serve on juries to help decide the outcome of legal trials. We select judges and law enforcement, either directly or indirectly, again, to represent implementation of the law. And of course, as citizens, we can advocate and we should conduct our elected officials, express our support or opposition to laws and policies. And I would argue that it's our civic duty to do that before we need them, to build those relationships early on, so that when we have a particular perspective, our elected officials are much more likely to understand who we are, know what we're doing, and to engage with us. Next slide. I say all that public health also has a role in democracy. Public health is foundational to civic well-being, social stability, and community resilience. In order for this to work, public health professionals must be active and participants in this civic dialogue, not silent technicians. And I say that because a lot of our colleagues believe that the evidence speaks for itself. And that if we do work and we write documents, we put it out there in the public visibility for the public, that they'll get it. And the answer is that's not true. It does not work that way. Facts are driven by science, evidence, and data, and the lived experience. We interact to shape just and healthy communities. And if we don't interact, we don't end up with just and healthy communities. So with that kind of an introduction to kind of our linkage to democracy, let's go to the next slide. And let me tell you that the United States has a health policy agenda, and every person who comes into office in any of the public health jobs or any cabinet official at the national level walks in with the 2 or 3 things they think that they want to accomplish while they're in office. But they also absorb an existing health policy agenda. So let me tell you the agenda that the administration, when they came in a year ago, was already on their table. We had reductions in life expectancy that had happened, was going down pre-COVID and then was gotten worse during COVID. And the good news is post-COVID, it's come back a bit, not back to pre-COVID levels. And just the other day, we saw that life expectancy went up a little bit more when we factored in some of the new things that have been done on particularly opioids and addiction. We have a growing healthcare crisis. Our healthcare costs are now over $5 trillion annually. I remember when we were freaking out over $1 trillion in healthcare costs on an annual basis. We have a growing number of problems with healthcare coverage. The Affordable Care Act actually would have gotten us to almost universal healthcare coverage. But when the Supreme Court undermined the Medicaid requirements for coverage, and then several things that have happened recently, we're now seeing more and more people who are losing healthcare coverage. We now have 1.5 million people less covered this year than we had last year. And we're rapidly going over 25, 26 million people who are still uninsured. And we have a large number of people who are underinsured. And then we have some targeted areas, gender affirming care, reproductive rights, and even access to emergency medical care that are under attack in our country. We finally got everybody to understand the fact that 80% of what makes you healthy occurs outside the doctor's office, and the social determinants of health were a key component of making you healthy. In fact, that's one of the areas in which we differ from other industrialized nations. We don't invest enough in the social determinants of health. And then, of course, we're an aging society. Long-term care, particularly Alzheimer's disease, is continuing to ravage our communities as the baby boomers age. We're living a little longer, but we're living a little longer, in some cases, less healthy. Next slide. We have significant issues with food insecurity, and as you know, we recently had a reduction in funding for SNAP. Food safety continues to be an issue. The last time I checked, we had over 1,400 foodborne outbreaks that were being addressed by both a combination of CDC and FDA. They tend to be small foodborne outbreaks, but it's still a big issue for us. Just when we thought we got our hands around significant tobacco control, we have brought tobacco utilization down dramatically in our kids. We are beginning to get our hands around it in adults, but then we now have vaping, which is now bringing utilization of an addictive substance back into the forefront. We have a growing mental health crisis, which was exacerbated by the isolation during COVID, particularly among our kids. And now it's being exacerbated because of the enforcement activities that are going on in many of our communities through ICE. Chronic disease, including cancer, continues to remain an issue, particularly chronic disease from cancer, lung disease, which of course we again gotten our hands around with tobacco control. That's becoming a big issue. Next slide. Climate change is here. It's impacting our health today, no doubt about that. Certainly we're having much more severe weather, more ice in places where we didn't see it, and snow in places where we didn't see it before, more severe weather, more rain. And our communities just aren't built yet to address the climate change problems. And we still have phenomenal problems with climate change deniers in our community. This current administration is pushing back a lot on many of the environmental protections that we thought we had in place, even going back to fundamentally re-question the Clean Air Act, the Clean Water Act that we had. We had convinced the Biden administration to once and for all begin to address lead exposure. Flint, Michigan brought it to the forefront of our conversation, but the fact is lead has been a problem in all of our central cities, particularly the fact that we use lead-lined water pipes in almost all of our major cities today. And we were in the process of replacing the lead-lined water lines in all of our countries. Hopefully the Trump administration will continue that project. I just saw the other day where Flint once and for all was able to replace all of their water lines. Next line. and lots of infectious disease threats. You know, we have measles outbreaks in 17 of our states. South Carolina is now the new poster child for measles, primarily in unvaccinated communities, mostly through primarily introductions from people who are infected who come into those communities, sometimes from outside the country, sometimes from inside the country. But we're also now self-infecting ourselves through people from these states going to other states in the country. Sexually transmitted disease, particularly syphilis, has been on the rise for several years. And we now have seen the return of neonatal syphilis and maternal syphilis as a big problem in the country. Because of climate change, we're now seeing vector-borne diseases in places of the country in rates which we had not seen before, the return of malaria, Lyme disease in more communities, and then the H5N1 bird flu outbreak, which has been hovering for a while, for some years now. We're now seeing it in species that we had not seen it before, including dairy cows and meat cows in the country. Next slide. You know, the Obama administration, the Biden administration, and the Trump administration have all talked about the opportunity for us to once and for all address HIV. I got into public health during the beginning of the HIV/AIDS epidemic, and believe it or not, that was when we didn't even know what the disease was. And now we have the opportunity once and for all to totally stop the transmission of HIV/AIDS in our communities. Totally stop it with medications that are easy to utilize, where we can get high compliance. That plus safe self practices should once and for all stamp out HIV/AIDS on the planet. And yet we've pulled back on PEPFAR and other things that would do that. Hepatitis C, we can finally totally cure hepatitis C. We just have to screen everybody, because most people don't even know that they're infected with hepatitis C. And we're now, of course, with some of the changes in the vaccine recommendations at the federal level, we're probably now going to see the return of hepatitis B to newborns and young children in our country. Next slide. And then injury, gun violence continues to be a plague on our community. We're still the most violent nation on the planet, industrialized nation with gun violence, and other injuries continue to be a big issue. Misinformation and disinformation are driving violence as well across our sectors. Next slide. The Trump administration's health policy to date, so far they've worked very diligently to increase the number of people who don't have access to health care by cutting funding for the Affordable Care Act and the health exchanges in particular, going after gender affirming care, regardless whether you're pro-life or pro-choice, going after reproductive rights in a very expansive way. Limiting funding for research and topics around diversity, equity, and inclusion, and gender affirming care. Also, just undermining the whole structure of our federal research enterprise. I was in China just in December, and they are eager and excited about eating our lunch on research. It's really a shame what we're doing. The good news is the federal government, the Congress has said that the funding for the federal government to do research will not be cut. In fact, they've increased funding at NIH, although they have whacked the Agency for Healthcare Research and Quality, which is the research enterprise which helps us know how to do provide healthcare safely and effectively and efficiently. Nonetheless, at least the Congress is providing the resources, even if the federal government is refusing to use it. Dramatically and indiscriminately reducing the size of government, reducing our healthcare workforce. We're going to have money, but we may not have people to implement some of the things that they're doing. And that's a real problem. And then many of the anti-immigrant actions are actually resulting in people being afraid to go to care. It's kind of like being in a communist country where you can see freedom, but you can't get there. People can see the emergency department. They can see the hospitals, but they're afraid to get there because of these anti-immigrant actions that they're doing. And even doing silly things like cutting funding or the regulatory actions for nurses in long-term care facilities. Those of us who have provided regulatory oversight for long-term care facilities know that it's the nighttime, it's the nursing staff cuts that result in bad things happening in our nursing's long-term care system. And then, of course, they're pulling back on our interaction with the global world through not participating with the World Health Organization, eliminating USAID, and just putting barriers in the way for CDC to engage in effective ways with our global partners. We're in a globalized world. Our food doesn't come from one place. Infectious diseases don't come from one place. Products don't come from one place. And so not interacting with the rest of the world is a fool's errand. And I would argue that the tariffs have been put in place too, which are done for all kinds of ridiculous ways, have caused us real problems. Next slide. You know, the secretary's fetish about limiting fluoride in our drinking water, the definitive work that they've done to destroy our national public health infrastructure, in inappropriate use of research studies, using data and sharing data that they shouldn't be sharing for a range of nefarious purposes is really a real problem. Next slide. And then many of the unscientific changes that he's done to vaccine policy. You watch this and basically putting people who are not highly qualified on these vaccine advisory committees and not even using the systems that we have to get advice and guidance from the professional societies and from all these people, mislabeling them as being conflicted, when in fact, the Secretary and many of his cronies are clearly conflicted by many of the things they're doing. And the most recent change, our pediatric vaccine schedule, if you go to the next slide, which is a real problem. And as you know, they reduced dramatically the number of vaccines that kids can get, changed the rules around that. This concept of shared decision-making is a misnomer. It is not informed consent. It creates a great deal of confusion and has resulted in people not quite really knowing what to do. Next slide. And just to give you an example, this is from their own chart, where they've shown that basically most people, the green on these charts, are the nations that are proposing those vaccines, and the red is where they don't. You see the preponderance of nations in the industrialized world do recommend all these vaccines for their kids. Next slide. I mentioned before gender affirming care being in the crossroads. This is a complicated issue, but health officials had really understood this and had policies and procedures, and we're going to have to work our way through this because this is ultimately going to result in children who need to have this care not getting this care. Next slide. And as you can see, trust, one of the reasons they said that they were trying to make all these changes was that people would trust us and that the public health system had lost trust. What you can actually see here is that less trust has occurred because of many of the things that they did. And quite to tell you, the secretary also said not to trust him, and he's correct. We shouldn't trust him. He's a lawyer, he's got no health background, and the acting CDC director shouldn't be trusted either. The election you can go to the next slide. We had the election in 2024. The Republicans did get a trifecta of the House, the White House, the Senate, and the House. They also have a very sympathetic Supreme Court. But note that the many margins for many of these folks were tight. And normally in tight elections, you get a lot of compromise. But there's been such extreme partisanship that compromise has been very, very difficult. Next slide. But, you know, there are some fundamentals of politics. There are limits. And historically, all parties, when they thought that they had a mandate, they've overestimated that mandate. It often forces them to overreach. Of course, President Trump is in his second term. He's rapidly becoming a lame duck just because of normal political processes. And then after the midterm election, he will, like all presidents, fundamentally become a functional lame duck. He may get some of the things he wants to do done, but he's politically going to be a problem. And of course, he's overreached in so many things so badly. And some of these inhumane policies, I think, are going to accelerate his lame duck status and his inability of his administration to do very much. Next slide. And of course, the Congress so far has been ineffective. You remember Harry Truman labeled Congress that time as the do-nothing Congress. That resulted in people projecting that he would not be reelected. And of course, he was reelected. So what happens in Congress makes a big difference on the national stage. And I hope what we're seeing is some cracks in that, and Congress is beginning to begin to address the needs of the American people. Next slide. We are beginning to see retaliation. We actually had the Department of Justice and NIH send letters out to researchers who were coming to our meeting to tell them they couldn't come. Some of them ignored those letters. Some of them came anyway on their private time. I'm not aware of anyone violating the law or their rules, but we did have less federal participation than we've normally had at our meeting this year. Next slide. They went after the American Academy of Pediatrics because of the lawsuit, which we are also a participant in that lawsuit. And of course, the AAP sued them, and a judge has ruled in their favor. Next slide. So now what? How do we deal with this from a policy perspective? Next slide. So obviously, when the federal government pulls out, it is an opportunity for civil society to be more engaged. Next slide. And so during COVID, APHA had put together a group called the Alliance for the Public's Health. And this alliance is a multi-sector coalition, which has worked to try to keep it from tripping over one another and kind of move in a collaborative way for a lot of things. So we brought that alliance. We kept that alliance going after COVID. We created something called FERN, which I encourage you to go take a look at. It's a wonderful resource navigator, which has a lot of resources to try to move public health forward. Next slide. But we also recognize, particularly when we started looking at what the administration was doing, that we needed even a more proactive response. So we created something called the Campaign for the Public's Health. So you go to the next slide. We decided that we ought to follow some core principles, a very focused approach in what we do. One, to make them follow the law. So we've done a bunch of lawsuits, forcing transparency, informing the public of the impact of their actions so the public knows what's going on, resisting anticipatory obedience. One of those anticipatory obedience is when they said diversity, equity, inclusion was reverse discrimination. We disagree with that. We believe that if you're for diversity, if you're not for diversity, you're for homogeneity. If you're not for equity, you're for inequity. And if you're not for inclusion, you're for exclusion. So we disagree with their perspectives on DEI, and we've challenged them in court on that. As you know, there's a 13th, 14th, and 15th Amendment, as well as amendments around women's rights, the right to vote, which argue that we should have diversity, equity, and inclusion in our country, and that is a core value of the American Public Health Association. And also, we think that in many cases they're bullies, and we should have no fear. They only have the power that we give them. So next slide. So to give you the idea what the campaign's been doing, next slide. Again, it's a collaboration, but this one, of course, is also across sectors. The idea is to do more about a short-term defense, but also to begin to go on a political offense to try to address some of the problems and challenges we're having. Next slide. We've created a rapid response action center to respond quickly to, we've hired a campaign coordinator. We're looking at bringing both grass tops and grassroots advocacy. bringing in legal and litigation support, and doing research and analysis to better understand, so we're making data-driven decisions as we go forward. Next slide. Once you click on that 3 times, and this is one of our lawsuits, the National Council of Nonprofits versus the Office of Management and Budget, which was to go after OMB for many of the what we believe illegal acts around cutting funding and cutting staff. Next slide. Our lawsuits against versus the National Institute of Health for pulling back grants on diversity, equity, and inclusion. This lawsuit has resulted in the administration being required to give those grants back. So those grants have been restored. And there's a second part of this where there was a lot of people that were in queue that had not yet gotten their grants. We came to a settlement agreement with the administration so that they're now processing those grants. And some of them will get through and some of them won't, but they're being reviewed on the merit, not on ideology. At least that's what they're supposed to be doing. Next slide. This is another one where we've gone after them around collective, for union rights, collective bargaining, again, trying to deal with some of the shutdowns that they did when the government was shut down to try to restore people's jobs. And this is proceeding as well. And we believe so far that the courts have been on our side. And then the next slide. This is the one where American Academy of Pediatrics led this against RFK. We are a litigant. Our goal was to address the dramatic changes in the Advisory Committee for Immunization Practices, the changes in the vaccine requirements for kids and pregnant women. We're asking the court to reverse those decisions. And we've now added to that lawsuit the dramatic changes in the vaccine schedule for children. And in fact, these are being debated on the 13th of this week. We're in court making our case to the judge. Next slide. This past week, we decided we needed to bring all of these collaborations around the country together. We called it a war rooms meeting. The idea was to coordinate, convene groups to try to better get everybody going in the same direction, keep us from tripping over one another, to make sure that we're now exchanging business cards now than when we need people. I've always argued that the worst time to exchange business cards is in the middle of the disaster. And we brought together a range of people to do this. It was a very successful meeting. And you're going to see a much more proactive public health movement going forward. And it includes not just public health, but healthcare, education, environmental groups, housing groups, anyone that has anything that's going to address the health and well-being of the American people. Next slide. And of course, you can participate in that too. We need everyone. Our goal is to build and incorporate the strengths of all the current efforts around the country, to build strong advocacy efforts, to speak truth to power, to not be afraid, to engage in research and do evidence-based decision-making, and to bring the American people on our side. This is going to be very important that we get the hearts and minds of the American people as part of this process. Next slide. I would argue that our ultimate goal is to get universal healthcare coverage for all people, to get costs under control for all people. I would argue that we need a national all-payer system to simplify delivery in our payment systems. Our systems are much too complex. Get an interoperable health information highway. It's a shame that this nation doesn't have universal access and Wi-Fi all over our country, that we can't even move an EKG across the street when other nations are able to do this, and other nations have shown they can do this. We need to, as an ER doc, it's painful for me to admit that primary care is the way to go, but primary care is absolutely the way to go, and we need to enhance our primary care systems. We need a national workforce strategy and improve the shortages and the maldistribution that we're seeing in our system. We absolutely have to invest more in the social determinants of health, and building the next generation public health century is at the core of this. Next slide. With that, let me thank you, and I'm happy to take any questions that you might have. I like this closing slide from Booker T. Washington that a lie doesn't become truth, wrong doesn't become right, and evil doesn't become good just because it's accepted by a majority. And I thank you.
Wow, that was fantastic. Thank you very, very much, Georges. So for those of you who have any questions or comments for Dr. Benjamin, please unmute, or you can raise your hand electronically. Libby, did you raise your hand, or was that maybe just a wave? No. Anyway, feel free to unmute and ask a question. I will ask. Start us off. Thank you very much. That was a really tremendous overview, Georges, of what all the huge breadth and depth of what your APHA is doing under your leadership. So thank you. The couple of things. One is on your book, which is I highly recommend. We've bought 25 copies that we'll be raffling off for those who work at MaineHealth, because we have an easy way to reach out to you who are attending live. But if someone in the audience finishes your book, say this weekend, they read it, and they want to take one concrete action on Monday morning, what would you advise them to do?
I would advise them to go meet their elected officials. Get to know them. Look, you folks are experts. You have an extraordinary expertise. And they need to know you, whether it's the homeowners association or the school board or your city council or your county council or your state elected officials. They put their clothes on just like you do. They live in your neighborhood. They're really there to serve you. And I think that you can provide them a perspective of what you believe. And you don't have to believe what I believe. You believe what you believe. You believe what's in your best interest based on your skill, expertise, and experience. And I have confidence if you do that, then they will get good advice, because you wouldn't be in this business. You wouldn't be in public health. You wouldn't be advocating for your communities if you didn't care.
Oh, that's great. Yeah, excellent advice. And so no matter what level, it could be local elected officials or federal or statewide, but just be in touch with elected officials and get to know them. So I'm hearing you say. You've been through so much. When I was reviewing your career and learned some aspects of your career I didn't know before myself, even though I've known you for a lot of years. And it's remarkable how much you've been through in the 23 years you've been leading APHA. And here we are in such a very challenging time. What gives you hope? How do you get resilience of leading APHA for all these years?
Yeah, my grandkids. I've got 3 of them.
Your what again?
Bright,
I'm sorry.
My grandkids.
Oh, your grandkids. Oh, yes.
They're bright and energetic, and active. I mean, they speak their minds. They're not pacifists. They know what's going on in the world. They're paying attention. My 12-year-old granddaughter was part of a school walkout the other day for ICE, protesting ICE, some things that ICE was doing in their community. And the school was very good. They helped the kids do this. They helped them do it safely, and legally, of course. So the fact that 2 generations, my folks are socially active. I mean, I grew up just wanting to practice medicine and be a good scientist, and I'm glad to see that. That gives me hope.
Oh, that's great. Your book's premise is the only policy can fix what policy is broken. So can you unpack that a little bit? I mean, you've talked a little bit about it in your talk today, but what does that mean in practice, especially for public health practitioners who may not see themselves as policy professionals?
Yeah, I tell people that policy is people. The people you put in these jobs, they bring perspectives, they bring approaches, they bring skills to the table. If you don't believe that, look at the fact that we have incompetence at the National Health Department, right? We put someone without the proper training, with no administrative background to manage something this big and complex, and doesn't understand health at all, and then is driving an ideological war on the health of American people and then saying that's not what he's doing, who lied to get the job. Now, obviously, I have a perspective on Secretary Kennedy. Whether you agree with me or not, I have that perspective. But everything he's changed is around his policy. And when I was practicing emergency medicine, it was real clear that I thought I was a decent doctor and I could take care of the person in front of me. But I got to tell you, a woman came into the ED one night with chest pain, and she was older, so she got the classic cardiac workup. And of course, as part of getting her undressed to do her EKG, we noticed that her pain was in her chest because she had a mass. She had an ulcerating cancer on her breast. And when we talked with her and said how long that mass been there, she said, "What mass?"
Oh my gosh.
And think about the number of, and she was uninsured. And so just think about the number of systems failures that brought that woman into my emergency department.
Wow.
Okay. Lack of screening for breast cancer.
Wow.
The fact she wasn't insured. The fact that she was lower income. Just think about the systems failures that brought that woman there. I don't know whether she had metastatic disease, but she certainly had ulcerating disease on her breast, even if she had a mastectomy and didn't have metastases, which I doubted. That was a systems failure, okay?
Wow.
And everybody who practices medicine today sees those systems failures. Every social worker in our country sees those systems failures. And the problem is, in the most wealthiest nation on the earth, we don't need to have that. We can fix those problems. We know how to do this. That's what's disappointing to me.
Yeah, no, that makes sense. And just, you talked about violence and you touched upon the violence in the talk, and I just got a breaking news email or text about the fact that there's been a school shooting in Rockville, Maryland, right near where you are. So, as a case in point, it's just, it's horrible that we have to live through.
And Rockville is generally a high income community.
Yeah, and it is, yeah. Anyway, so Jennifer's got a question about, is there enough budget to make the court challenges? Jennifer, are you talking about APHA's budget, or do you want to just unmute? But this is your opportunity to give a pitch about donating.
Well, let me tell you something. We need more money. We need more members. The best way to give us money is to first be a member and to engage in our advocacy, because your sweat equity has enormous value. So become a member, and engage us with using your sweat equity, and then donate whenever you can as a donation, because we absolutely do raise money. The good news is that we've been able to get all of this legal support pro bono so far. Now we are serving as a fiduciary for one of the lawsuits where money is being raised, and we're kind of paying the bills. But the good news is we are the law. There is a law community that is ethical, is very concerned about what's happening in our country, and is providing a lot of this support pro bono. Now, some of them are raising money. Some of them are going to reserves. Some of the partners are contributing to cover these costs. But so far, you're seeing, my staff and I are up 24 hours a day, 7 days a week. I'm getting phone calls at 2 or 3 in the morning from people who want to talk about issues. I'm on the phones till midnight, often with attorneys, try to talk about strategy and things like that. So,
Wow.
But you can help with that. You can be parts of that.
I put the link to the APHA's website on membership. So yes, please, anybody who wants to consider that, that's right there. Chris Lyman asked about, can you speak more about the challenges of countering mis and disinformation?
Yeah, I still believe that the best way to counter dis and misinformation is with good information. What we don't have is, these folks flood the zone. They're very good. There are people out there who are actively putting in disinformation because they wanted the information to be wrong. Also, you need to know there are foreign actors that are out there that are leveraging, the schoolyard bully who sees two people having a fight and fight and cheering you along. We have other countries that are doing things such as they go into pro-life web chats and put pro-choice stuff there, and then they go into pro-choice stuff and do pro-life stuff. They do that on guns. They do that on gender-affirming care. They do that on human rights. They do that on race. What are they doing? They're in effect doing A/B testing. They're testing messaging because then they use to understand how Americans behave, and then they go and use that to try to influence our elections. You can be darn sure that other nations are, one of the reasons I talked about democracy earlier, is that our democracy is at risk in a lot of ways. And so with disinformation, and I think that we spend a lot of time talking about rebuilding trust. For me, the best way for us in public health to regain trust is, first of all, be seen. They need to see you in the community because, we had a problem with COVID. We had an unknown person telling people they had to wear a mask, had to take a shot, and had to stay home, and they couldn't go to work in some cases, right? Their lives were upset by an unknown bureaucrat whose powers they didn't understand, our police powers. And they revolted against that. And then our politicians, quite frankly, in many places, didn't stand behind us. So if the community knows us, they will trust us, they will engage with us, and we have to tell them the truth. We have to do what we say, and then we have to let sure people know we did what we said we're going to do. And this idea of when our best work is done, nothing happens, that's okay. But when nothing happens, we need to remind people nothing happened and who did it.
Yeah, that makes a lot of sense. Thank you. Tim Cowan, I think I saw you raise your hand earlier. Are you on? Did you have a question?
Yeah, Dr. Benjamin, thank you so much. It's great to hear your wisdom and your energy and enthusiasm. So thanks for the motivation. In addition to your recommendation that I fully support of talking with our elected officials, I'm a city councilor in a small city here in Maine, so I can say it's really, really helpful to hear from people. I'm wondering if you have thoughts, guidance on, are there other organizations or sectors in their communities that would be advantageous for us to advocate and talk with in order to then encourage or empower them to advocate with their elected officials?
Oh, yeah, absolutely. I mean, the housing community, the education community, look, the Maha community. We got to start talking with them. Okay, don't just dismiss them. They're a serious player. Sometimes they're informed and sometimes they're misinformed. But don't go with this idea that they're evil or someone we should walk away from. We need to talk to them. We need to engage them. One of the reasons that they have been able to be enveloped by others is that we kind of, in my mind, took them for granted, and we shouldn't do that. So I actively engage them. No question about that. And anybody wants to talk to us, we ought to talk to them. Anyone wants to engage with us, and if they disagree, that's okay. As long as we can have an intelligent conversation, and even if we agree to disagree, still work with them as much as you can around the things in which you can agree on, as much as we can.
Great
Thank
advice. Thank you. And thanks, Tim. Tim is an epidemiologist who works at MaineHealth, but as he mentioned, he's also the city council, serves on the city council as an elected official at a small city but nationally, but a big city for Maine. So
That's right. That's right.
Thanks. But yeah, do you have time for probably another question? I see Lonnie Graham, who is our former state health officer and state epidemiologist. She preceded me. So she was, I was 96 to 2011, and she was, 90 to 96, something like that. So you also might have overlapped in some way. But Lonnie, yes. Oh, Lonnie, I think I saw your hand up. Lonnie, are you getting unmuted? Well, let us know, Lonnie, if you're getting unmuted. Sorry. Just start talking. Oh, she can't unmute, she says. She writes down in the chat. Well, keep trying. So if you do, just shout out and we'll fit you in. Hyatt Freeman, thank you for raising your hand. Want to unmute?
Hi, thank you for being here, Dr. Benjamin, and Dora for hosting this. So my question is, with the changes in healthcare, and Dr. Benjamin, you spoke about the lack of screening, the lack of healthcare, and how the system's failing early on in your speech. So with that in mind, with changes in healthcare and increasing numbers of Americans without healthcare coverage, and where do you see the future of our system with regards to the needs of the American people who do not have health care, and their physical status and their mental status with that void, if you will, in their lives, and being the richest nation in the world, if you will, where do you
Yep.
see that down the
Look,
pike?
I mean, the answer is that every time this nation has done major health reform, is because the status quo has become unacceptable, and everybody's second choice has become the default. The ACA was nobody's first choice. It was everybody's second choice behind whatever they thought, single payer or Medicare, Medicare for all, something different other than that, a totally private model, getting all employers out of it and doing something different. I mean, everyone had a different model back in those days. We're going to see it again. Right now, people are healthcare is unaffordable for the average American. There's been enormous cost shifts to out-of-pocket costs as a way to control costs. And so we're going to have the next election is going to be a healthcare election, I believe. It's going to be a major tenet whoever runs for office. And so we ought to be starting now thinking about what the next generation public health system ought to look like. We don't want to rebuild what we had before. We want to build something different. What is it? What is a healthcare system with everyone in and nobody out? Whether it's Medicare for all, whether it's something else, I don't know. America always like to do something uniquely American, whatever that is. I have some ideas, but I think that we ought to do that. I argued, you saw in my slides, a national all-payer system. Maryland doesn't have uncompensated care for hospitals because we have an all-payer system, which is complicated to explain. I couldn't explain it right now in the time we have, but national all-payer system would control costs. It basically creates a global budget. Getting everybody in. You cannot control costs until you fix the leak. The leak is the number of uninsured and underinsured people that we have. Okay. Right. So there's some things we can do, but the public health piece of this, we need just like we built a national highway system, we need to actually fund a national health information technology system. And if you don't think we can do it, let me just refer you to some things that like DoorDash and Uber and Amazon, they have figured out how to take your data and share it and do that in a confidential manner. They have breaches every now and then. But right. we run for cover to send health information just across the street. It's a terrible tragedy.
Just a quick comment, if you can, under a minute, perhaps. What do you think is the contributing factor that healthcare is such a sensitive, if you will, a crutch for the U.S.? I mean, why is it such a thorn in their side that they can't grasp at what is required?
It's very personal. Healthcare is very personal. And we need a message. I mean, it is in some ways a communications issue, but more importantly, anytime that systems don't want to change, you have to ask who benefits. There's a lot of people making money on this dysfunction. A lot of people making money on this dysfunction. There are a lot of people making money on the lack of unhealthiness in this country. Mm-hmm. There are a lot of people in office right now who keep talking about health. One of the reasons they're talking about health is that they're going to make a lot of money on supplements and unproven therapies and things like that. A lot of money in the system. And the question is who benefits and who's making the money.
Yeah. Well,
thank you so much.
Dr. Benjamin, this has been fabulous. Really appreciate your time. I do want to put a quick plug in for our next Grand Rounds, Public Health Grand Rounds, is February 24th. And Tim Cowan, who asked a question a few minutes ago, is going to be reviewing some new public health data sets, such as Pop Hive and Places, and some other new public health data sets that you may find interesting. And then we have also some national speakers coming up later in the spring, including Michael Osterholm and some others. So, so please go to our website they're all free, and please feel free to register for them. Dr. Benjamin, thank you. Cannot thank you enough. You have been very energizing. I can see a lot of people giving us a thumbs up and heart signs and all kinds of things, symbols that are their symbol of appreciation for your time today. And you're just getting us energized about public health. So deep gratitude. And
Can I say one thing?
Yes.
APHA in November, right before the election in San Antonio.
Yes, it's actually during the election, right? It's like November.
Yeah, we overlap it by a day. Yeah, unfortunately. Yeah.
But yeah.
So you got to vote early and often. I'm from Chicago, so yeah. Early and often.
A quote from an old Chicagoan, right? your hometown. Thank you so much, and we will see you in San Antonio in early November, if not before, Dr. Benjamin. Thank you. Thank you for all your work. And
thanks everyone for coming.
Thanks, everybody.
Bye-bye.
Bye-bye.